Mansi, can you start my camera?
Hello, we'll do it, sir. We'll do it. Hello.
Hello?
So now you can start your camera.
Yeah. I don't know, something is happening. I know. Even.
Hello.
Hello, Mansi.
Hello.
Can you hear me?
Yes, yes. I sent the request to start your camera.
Yeah. Okay. I started my camera. Can you see me now?
So the camera is on.
Yeah.
Just leave and rejoin the meeting on same link.
You want me to rejoin the meeting once again?
Yes, yes, yes.
Yeah, okay.
Yeah.
Can you see me now?
No, sir. Hello.
Hello, can you see me now?
No, sir.
I think I'll just once again I'll try just 1 minute.
Yeah.
I think I'm not seen, no?
Sir, I can't see you.
It doesn't matter. I think we can, doesn't matter. I can start presenting without my video. There is some problem here.
Yeah, there is some problem, I guess. Because I sent.
Yeah, I will start without wasting time. Okay, at least they can hear me.
Yeah.
Okay, so we'll start now. Is my screen visible now?
Yes, sir, your screen is visible.
Okay, that's enough. That's enough.
That's okay. Yeah.
So good evening to all of you. This is my 67th, 68th session on the challenging case series. As usual, I will start with the short case first. Not a short case, in fact. This is a story of a 60-year-old diabetic person. His history starts 5 days back as a history of acute onset of vomiting, giddiness, tinnitus in the right ear, and inability to walk, and with subsequent staticos. On the third day, he said he hears every sound as two. That is the history. So 5 days history of acute onset of vomiting, giddiness, tinnitus of the right ear, and inability to walk with a staticos. I think this history part I will skip because what he's telling is the same thing which was already told. But go to the findings now.
லைட்லேயே பாருங்க, பார்த்துட்டே இருக்கணும். என்ன
Yes, good.
லைட்லேயே பார்த்துட்டு இருக்கணும்.
Right,
கண்ணை அசைக்காது.
horizontal. Direct nystagmus or looking to the left side.
இந்த பக்கம்
No rotary component, no nystagmus.
கண் அடைக்காது.
Right side.
அப்படி பார்த்துட்டே இருக்கணும், அடைக்கக்கூடாது. ஓகே, இங்கே நேர பாருங்க.
Primary position, there is no nystagmus.
இனி இடது பக்கம் பாருங்க.
Look to the left side, again the nystagmus appears.
இன்னும் முകളിல் பாருங்க.
One moment is normal.
கீழே பாருங்க. இந்த பக்கம்
There is no nystagmus, again look at the right side.
இந்த பக்கம் இங்கே பாருங்க. இங்கே பாருங்க, லைட்லேயே பாருங்க.
Left side it is appearing again.
அப்படி இருக்கு, அப்படி இருக்கு. என்னையே
And the contrast
பார்த்துட்டு கண்ணங்க தசிக்கக்கூடாது. என் கண்ணிலேயே பார்த்துக்கிடுங்க.
Turning to the left side, nothing happens.
வேற எங்கேயும்
But on turning the right side, contrast is
ஏன் கண்
possible.
பார்க்கக்கூடாது.
You can see the catch-up again.
കണ്ണ് മാറുന്നില്ല. ഇപ്പൊ ഇങ്ങോട്ട് നോക്കുമ്പോൾ ശബ്ദം കേൾക്കുതാ?
And he has got hearing loss on the right side.
ഒട്ടുമേ കേൾക്കില്ല.
He said he's not able to hear at all on the right side.
ഇന്ന് കേൾക്കില്ല. മുറുക്കി അടങ്ങി.
Rest of the finding is normal. It's got only mild facial asymmetry on the right side.
വിടുങ്ങി വിടുങ്ങി വിരലിലെ തൊട്ട് മൂക്കിലെ തൊട്ട് അപ്പടി ചെയ്യും.
No finger nose in coordination.
തൊടണം. ഇതൊക്കെ മൂക്കിൽ തൊട്ടാണ് കറക്റ്റാ. இந்த கையாലോട് ചെയ്യുക.
Normal, tongue normal.
சத்தம் போடுங்க. இந்த தொடுதலும் தெரியுதில்ல ஒரே மாதிரி முடிக்காது.
Deep and pressure are normal. No motor weakness. Plantar downgoing. Sensory system normal.
ഇത് ഒരേ മാതിരി தெரியுதில்ல? ഇതിനെന്താ ഒരേ മാതിരി தெரியுதா? சரி. ഇത് தெரியுதில்ல? കിരികിരിപ്പ്.
Vibration, pain, all normal.
ഇതിന് தெரியுதில்ல? சரி.
Okay. I'll go to the gate. On standing, with eyes closed, you tend to stray towards the right side. Tandem walking was defective, tendency to sway to the right side. So that's the finding. So on examination, it's got right sensorineural hearing loss. Horizontal nystagmus with fast component to the left, present on left lateral gaze. Right lower facial weakness, Corey, whether it's a facial asymmetry, I'm not very sure. But he has got positive head thrust test on checking the head to the right side. On standing, patient's face to the right. So what is a localization, likely diagnosis?
Sir, vascular syndrome, acute vascular.
Okay, vascular syndrome, where do you want to postulate? It's an inside the labyrinth, acute labyrinthine infarct.
Seems to be like an ICA infarct.
Okay, ICA infarct. Right. Any other possibility? Why can't be acute labyrinthitis? Or in ischemic infarct of the labyrinth?
Yeah, I felt he had an sir. He had a skew, ocular tilt, OTR like.
Yeah, he has got a tilt actually to the right. Okay.
Yeah. So
that's the point we want to consider it as a central lesion.
yes.
But his head thrust is positive, suggesting a peripheral involvement.
That can occur. Head thrust can occur in peripheral lesions also.
Like it classically occurs in peripheral lesion.
Yeah, yes, but
bidirectional nystagmus is likely to be central.
He has got nystagmus only on looking towards the left side. No nystagmus in the primary position, no nystagmus on looking to the right side. It is not a gaze-evoked nystagmus. It is not a bidirectional or direction-changing nystagmus.
Okay, sir.
But sir, OTR occurs only in central lesions.
OTR says to central lesion. Only thing it's got a, as you said correctly, it's got a head tilt, but that point is favoring a central lesion, agreed. But in fact, that can also occur with peripheral lesion as well. It's not a strong point, but not commonly seen. Commonly, it is seen only with central lesion. So, okay. So, how many would you think there is a labyrinthine involvement? How would you think it is a central lesion?
Combine both.
Yeah, it can be both, correct. Right. So, the point is that can you get this type of nystagmus in central lesion? Usually, side beating nystagmus only in one direction is seen in peripheral lesions. Okay, so what do you want me to do now in this patient? MRI? Okay, MRI shows, as you said correctly, says infarct is the lateral medulla here. Okay, and in the cerebellum. It's got lateral medulla here and in the cerebellum. That is inferior cerebellar peduncle. It's also got infarct in the inferior pons also is affected. And the middle cerebellar peduncle. This is angio, forget about it. So in fact, he has got infarct on the right lateral medulla, as well as the vestibular root entry zone in the pons. Now my question now is, how do you explain the nystagmus in this patient? What is the nystagmus known as? This is called pseudo-vestibular neuritis. Rarely medullary lesions can also produce, or even pontine lesion can also produce, or vestibular root entry zone lesion can also produce a nystagmus mimicking a peripheral lesion. That is why it's called pseudo-vestibular neuritis, a beating towards to the contralateral side. Usually what you get in cerebellar lesion on one side is nystagmus, is gaze-evoked. It will be more towards the side of lesion. If the right brainstem is affected, you get a nystagmus more towards the right side, and the cerebellar connections are involved. If the nystagmus is on the contralateral side, that is typical of a vestibular lesion. But rarely this can occur in medullary lesions as well as lateral pontine lesions. That's why it's called pseudo-vestibular neuritis. And head thrust can be positive, usually seen in peripheral lesion, but can be seen in the central lesions as well in the case of Vestibular root and zone or vestibular nuclear lesions can also produce positive head thrust test. But that is not common, but can occur. So the point I would like to mention is that the positive head thrust test need not take you away from a vertebral basilar infarct or brainstem lesion. One, the side beating nystagmus only one direction also can rarely occur in medullary lesion. As the doctor has already pointed out, that head tilt is one clue, important clue to suggest a central lesion, suggesting a skew deviation or a OTR. Okay, any questions? Two, 3 sentences about pseudovisceral neuritis. It is caused by unilateral or fascicular lesions of the entry zone of the eighth nerve, vestibular nuclear lesions, or vestibular cerebellar lesions, mostly caused by infarctions or multiple sclerosis plaques. The signs and symptoms may mimic vestibular neuritis if there are no additional clinical brainstem and/or cerebellar signs. Acute unilateral peripheral and central vestibular lesions can cause similar signs and symptoms. Skew deviation was the only specific but non-sensitive sign in pseudoneuritis. None of the isolated signs like head thrust, saccadic pursuit, adhesive nystagmus, subjective vestibular decay were reliable. Okay.
And that hearing symptoms, sir?
Hearing symptom is you're seeing is why the hearing is affected is because the ICA is supplying the labyrinthine artery. The ICA in the labyrinthine artery or internal labyrinthine artery arises from the ICA. Sometimes it can arise directly from the vertebral artery, whatever the basilar artery. So here it is not from the vertebral basilar system is affected, vertebral artery is affected, causing ischemia in the pica territory and ischemia in the ICA territory. In fact, the right vertebral is hypoplastic and not visualized. See, this is the left vertebral, this right vertebral is not seen. You can see the basilar, but the other vertebral part is not seen. The right side.
Sir, if only the auditory artery is involved, sir, can we find anything on MRI?
If only labyrinthine artery is involved, I do not know.
Yes, sir.
And I don't think that usually the ICA is involved. You can get base involvement. If only labyrinthine artery is involved, you won't see anything in the MRI.
Okay, sir.
Okay, if no questions, shall we go to the next case? Any questions?
Sir, was it complete ocular tilt reaction in this patient, that torsion component, skew and all?
No, it was not there. In fact, we expect the eye skew deviation of the eye downward, but if at all the right eye is little up.
Okay, sir.
So that's not a complete one. Only the head tilt is there on the right. So that favors ipsilateral medullary lesion. A lesion before the crossing of the autolytic ocular pathway, so-called gravis septi pathway.
Okay, sir.
The ocular tilt reaction is due to the involvement of the autolytic connection with the interstitial nucleus accumbens. It arises from the autolytic organs, goes to the same side, ends in the vestibular nucleus, comes to the opposite side and ascend in the MLF to the contralateral INC. The lesion is before crossing, you get an OTR to the same side. If it is after crossing in the MLF or in the midbrain, it is OTR to the contralateral side. Here the lesion is on the right side, that's why it's getting head tilt towards the right side.
Yes.
If it had been a midbrain lesion causing this OTR, the lesion should have been on the left midbrain or left pons.
Okay, sir.
Okay. Shall I go to the next case?
Yes, sir.
Yeah. Now, this is a very interesting case. You have to put your mind on to analyze this case. This is an old case of type 2 diabetes mellitus and hypertension, 70-year-old man. In fact, this neurosurgeon called me from and said that he wanted to show me a case. This patient went to neurosurgeon for his complaint of imbalance while walking following COVID infection for the last 20 days. In fact, COVID infection occurred 1 month back. He took an MRI brain and found multiple lesions in the brain, which he thought that the lesions were not typical of any mass lesions, and that is why the case is referred. So when he came to me, I took a detailed history. History of having had COVID infection 1 month back, and he was all right prior to that. For the last 20 days, that is 10 days after the COVID infection, patient complained of profound insomnia. For the same duration, patient complained of radiating pain from the left hip downwards, which was more below the left knee. 3 days later, he noticed similar pain along the right lower. The pain used to wake you from sleep, no increase with coughing and sneezing. For the last 5 days, patient also noticed imbalance while walking and loosening of the chappals from his left foot. Also noticed numbness of the left leg and knee, and tendency to lurch towards the left side while walking. For the last 2 days, he complained of burning pain in the back of his chest. No complaints pertaining to the upper limbs, except for some vague shifting pain over both arms. No headache or any symptoms pertaining to cranial nerves. This is the story. So I'll go back to the history once again. History of having had COVID infection 1 month back. For the last 20 days, patient complained of profound insomnia. For the same duration, patient complained of radiating pain from the left hip downwards, which is more below the left knee. 3 days later, he noticed similar pain along the right lower limb. The pain used to wake him from sleep, but no increase with coughing and sneezing. For the last 5 days, patient also noticed imbalance while walking and loosening of the chappals from the left foot. Also noticed numbness of the left leg, knee, and tendency to lurch towards the left side while walking. For the last 2 days, he complained of burning pain in the back of his chest. No complaints pertaining to the upper limbs except for some vague shifting pain over both arms. No headache or any symptoms pertaining to the cranial nerves. Now let us see the video of the patient. The cranial nerves, the only finding is some asymmetry in the pupil, but no ptosis. Whether it's a physiological anisophoria, I am not sure. But it's reacting well, mildly.
Cataract surgery.
But he had undergone a cataract surgery, so probably it is related to that. Ocular movements are all normal. All cranial nerves were normal. The upper limb tone was normal. Or was normal in the upper limb. Or is normal in all muscles in the upper limb. There was no finger nose incoordination. Keeping his arm outstretched, nothing much. Was looking for any pseudotheta or something like that, nothing today. We could make it out clearly. The lower limb, the abdominal, there is no abdominal muscle weakness. Lower limb tone was normal.
ശ്രദ്ധിക്കുക, ചുമ്മാ കിടന്നാൽ മതി, വേറെ ഒന്നും ശ്രദ്ധിക്കരുത്. വീട്ടിൽ കാര്യം വെച്ച് മതി.
Or was normal, just were
പിടിച്ചോ,
normal.
മതി മതി വിട്ടോ. ഇത് പൊക്കിക്ക് വിട്ടോ. ഇത് മുട്ട് മടക്കിക്ക്, നൂർത്തെ ചവിട്ടിക്കാൻ. അത് അതേപോലെ ഇതും ചവിട്ടിക്ക് മടക്കിക്ക്, നൂർത്തെ. ഇനി പാദം മുള്ളോട്ടിരിക്കണം, കീഴോട്ടാക്കാൻ സമ്മതിക്കരുതേ, ഇങ്ങനെ ഇരിക്കണമേ.
Expression power is
ഇത് പൊക്കി പിടിച്ചേ,
weakness of the muscular
പിടിച്ചോ.
side.
ഇനി തള്ളവരിൽ മുള്ളോട്ട് പിടിച്ചേ, പിടിക്ക്. ഇതും പിടിച്ചേ,
That bit mildly weak on the leg.
മാക്സിമം പിടിച്ചേ. ഇത് പിടിച്ചേ, മാക്സിമം പിടിച്ചേ. ഇനി കീഴോട്ട് മടക്കിക്ക്, അങ്ങനെ പിടിച്ചോ. ഞാൻ വിടല്ലേ, പിടിച്ച നിർത്ത് വെച്ചേ, മതി. ഇതും പിടിച്ചേ, വിടല്ലേ, മതി. വിട്ടോ 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 വിട്ടോ. നീ ഇങ്ങനെ ഉള്ളോട്ട് പിടിച്ചേ,
Expression was normal.
ഇനി കാലകത്തി പിടിച്ചേ,
Just
മതി. വിട്ടോ 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 വിട്ടോ. ഇനി ബലം കിടന്ന് കിടന്ന് ബലം
the
പിടിച്ചൊന്നുമില്ല
reflexes,
കേട്ടോ.
biceps normal. Bilaterally. Supinate normal. Left triceps is absent. In three
ഞാൻ പറയുമ്പോൾ വലത്തെ കൈ മുറുക്കി പിടിക്കണേ.
three
വലത്തെ കൈ
also
മുറുക്കി പിടിച്ചേ, വലത്തെ കൈ മുറുക്കി പിടിച്ചേ, അത് വിട്ടോ.
right triceps is well extended. That is good below. Incheck it is absent. Position is absent.
മടക്കിക്ക്, അത്രയും വേണ്ട, പകുതി പകുതി. അങ്ങനെ ഇരിക്കട്ടെ, അങ്ങനെ ഇരിക്കട്ടെ. അതുപോലെ ഇത് മടക്കി വെച്ച് പകുതി പകുതി അങ്ങനെ ഇരിക്കട്ടെ.
The abdominal pressure is absent. Knee check. Both knee checks are absent.
എൻ്റെ കയ്യിലോട്ട് അമ്പലം കൊടുക്കരുത്, എൻ്റെ കയ്യിലോട്ട് കിട്ടാൻ മതി. അതെ, ചുമ്മാ തളർന്ന് കിടക്കണം നല്ലപോലെ.
In reinforcement. Angle check was present.
കൈ വിട്ടോ, ഞാൻ പറയുമ്പോൾ മുറുക്കി പിടിച്ചാൽ മതി.
Yes, present.
വിട്ടു. ആ മതി. ഇത് മടക്കി
The left ankle was also present. That is ankle. Hips are absent. Under was independent. That was normal all through.
കുറച്ച് ഇറക്കി ഉറക്കേണ്ടേ ഞാൻ പറയുമ്പോഴേ.
Able to count.
ഇതും വ്യത്യാസം ഉണ്ടോ? വ്യത്യാസമില്ലല്ലോ, ഒന്നുകൂടെ ശ്രദ്ധിച്ച്.
Both sides.
ഉണ്ടെങ്കിൽ മാത്രം പറയും, കൂടുതലോ കുറവെന്ന് പറയണേ. കൂടുതൽ
This on the left side.
ചെറിയ വ്യത്യാസം വിട്ടേക്ക്. എന്തോന്നാ അവിടെ കുറവ്. ഓക്കെ,
Now it's dedicated to the left.
ഇവിടെ
More
കൂടുതൽ
on the right lower ear. A bit of the left lower ear.
ആണോ? ആണോ?
More on the right side.
ആ ശരി. അപ്പൊ ഇവിടെ കുറവ് ഈ തമ്മിൽ ഇവിടെ കുറവാണ് ഇടതുവശത്തെ.
The left knee is
ഇത് ശരിക്കും കൂടുമ്പം പറയണേ.
where it says a level.
ഇതൊക്കെ ഒരേപോലെ ആണോ? ഈ കുത്തും തമ്മിലോ? ഒരേപോലെ. ഇത് തമ്മിലോ? ഇവിടെ കൂടുതൽ. നേരെ തിരിച്ചറിഞ്ഞില്ല ആദ്യം പറഞ്ഞത്. ഒന്നുകൂടെ
Is
ശ്രദ്ധിച്ച്.
the
ഇതിലിപ്പോ എവിടെയാ കൂടുതൽ? ഇവിടെ. ഇപ്പൊ കൂടുതൽ ഇവിടെ. ഇത് തമ്മിൽ ചെറിയ വ്യത്യാസം വിട്ടേക്കണേ. ഇത് തമ്മിലോ? അവിടെ കുറവ്. ഇപ്പോഴോ?
left side is it.
എവിടെയെങ്കിലും വ്യത്യാസം ഉണ്ടെങ്കിൽ ഉടൻ പറയണം. അവിടെ വേദന കൂടുന്നുണ്ട്. അവിടെ
It's an alternate sensation.
എല്ലാവരും ഒരു ഓൾമോസ്റ്റ് സെയിം.
അല്ല, ഇത് സൂചിക്ക് കുത്തുന്ന മാതിരി
അവിടെ
ഇവിടെ മറ്റെന്തോ പരന്ന സാധനം വെച്ചിട്ട്
Lower abdomen,
അവിടെ പറഞ്ഞ അപ്പോൾ വ്യത്യാസം വരുന്നുണ്ട്. അപ്പോൾ ഇവിടെ നന്നായിട്ട്
dull, like
ഈ കുത്തുന്നതും ഇതൊക്കെ ഒരേപോലെ അറിയാമോ? അറിയാം. ഇവിടെ നിന്നൊരു വ്യത്യാസം വന്ന ഉടൻ പറയണം.
there he said from
ഇവിടെ വ്യത്യാസം ഉണ്ടോ? ഇനി നോർമലാ
ഇതിലും ഉണ്ട്
കൂടുതൽ. ഈ കുത്തുന്നതും ഇതും തമ്മിലോ
ഇത് സൂചിക്ക് കുത്തുന്ന പോലെ
ഉടൻ വ്യത്യാസമുണ്ട്.
the aperture is an
ഇനി
alternate.
ഒന്നുകൂടെ ശ്രദ്ധിക്കുക.
Does not feel the pinprick on top of her.
ഈ നടുക്ക് ഭാഗത്ത് ശരി.
അവിടെ ചെറിയ വ്യത്യാസമുണ്ട്. ഇവിടുന്ന് മുകളിൽ കൂടുന്ന പോലെ തോന്നുന്നുണ്ടോ?
അത്രയും ചെറിയ പരന്ന മറ്റേ സൂചി പോലെയും
അവിടെ ഒരു പരന്നത് പോലെ, ചെസ്റ്റിൽ പരന്നത് പോലെ
The lower abdomen is pain.
തോന്നുന്നുണ്ടോ?
Dull pain.
ഇപ്പോൾ ഉണ്ടോ? ഇപ്പോഴേ
ഉണ്ട്
Vibration is normal.
ഇപ്പോഴേ
ഉണ്ട്
ഉണ്ട്. ഇപ്പോഴേ
ഉണ്ട് ഇതുപോലെയാണ്.
ഇപ്പോഴേ
Raise itself here.
Ah.
And he takes that.
ചെറുതാണെങ്കിലും ഉണ്ടെന്ന് കൊണ്ടെങ്കിൽ പറയണം. ഇപ്പോഴേ
ഉണ്ട്.
ഇപ്പോഴേ ഇപ്പോൾ ഉണ്ടോ?
ഇല്ല.
No vibration in the region. Right.
ഇപ്പോഴേ
ഇല്ല.
Does not feel.
ഇപ്പോഴേ
ഇല്ല.
Does not feel vibration there.
ഇപ്പോഴേ
ഇല്ല.
No.
ഇപ്പോഴേ
അവിടെ ചെറുതായിട്ടുണ്ട്.
ഇവിടെ ചെറുതായിട്ടുണ്ട്. ഇപ്പോഴോ
അപ്പോഴും അവിടെ ഉണ്ട് ചെറുതായിട്ട്.
ചെറുതായിട്ടുണ്ട്. ഇവിടെ
ഉണ്ട്.
There is able to be
ഇപ്പോഴേ
normal.
ഉണ്ട്.
ഉണ്ട്. ഇപ്പോൾ ഉണ്ട്.
ഉണ്ട്.
ഉറക്കം പറയണേ. ഇപ്പോഴേ
ഉണ്ട്.
ഇപ്പോഴേ
ഉണ്ട്.
ഇപ്പോഴേ
ഇല്ല.
Ankle and the toes is felt vibration, but not over the knee and the ankle.
ഇല്ലെങ്കിൽ ഇല്ല.
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 അവിടെ ഇല്ല.
ഇല്ല. ഓരോന്നും ഓരോ പ്രാവശ്യം പറയണം.
And checked again to find.
ഇപ്പോഴേ
കിരീടമില്ല.
കിരീപ്പാണ് ചോദിക്കുന്നത്. വേറെ ഒന്നും തൊട്ടത് വേണ്ട.
ആ
കിരീപ്പ് മാത്രം. ഇപ്പോഴേ
കിരീടമില്ല.
ഇല്ല.
No.
ഇപ്പോഴേ
ഉണ്ട്.
Feels there.
ഇപ്പോൾ ഉണ്ടോ?
There is not able to.
ഇപ്പോഴേ
അവിടെ ഉണ്ട്.
ഇവിടെ ഉണ്ട്.
അവിടെ ഉണ്ട്.
ഉണ്ട് ഉണ്ട്. ഇപ്പോഴേ
ഇല്ല.
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 ഇല്ല. ഇല്ലെങ്കിൽ ഇല്ലെന്ന് പറയണേ. ഇപ്പോഴേ
ചെറുതായിട്ടുണ്ട്.
ചെറുതായിട്ടുണ്ട്. ഇപ്പോഴോ
അവിടെ നല്ലപോലെ ഉണ്ട്.
അവിടെ നന്നായിട്ടുണ്ട്. ഇവിടെ കീഴോട്ട് കുറവാണ് അല്ലേ? ഇവിടെയാണ് നന്നായിട്ടുള്ളത് അല്ലേ? എങ്ങനെയാ?
There is not able to.
ഇപ്പോഴേ
താഴോട്ട്.
ഇപ്പോഴേ
മേളോട്ട്.
അതേമാതിരി ചെറുവരലി പറയണേ.
The upper knee.
ഇപ്പോഴേ
താഴോട്ട്.
ഇപ്പോഴേ
മേളോട്ട്.
ഇപ്പോഴേ
മേളോട്ട്.
ഇപ്പോഴേ
താഴോട്ട്.
ഇപ്പോഴേ
താഴോട്ട്.
ഇപ്പോഴേ
മേളോട്ട്.
ഇപ്പോഴേ
മേളോട്ട്.
The toes.
അറിഞ്ഞൂടെങ്കിൽ അറിഞ്ഞൂടെന്ന് പറഞ്ഞാലും മതി. ഇപ്പോഴോ
താഴോട്ട്.
ഇപ്പോഴോ
താഴോട്ട്.
ഇപ്പോഴോ
താഴോട്ട്.
ഇപ്പോഴോ
ഒന്ന് അറിയാൻ വേണ്ടി.
അറിയാൻ മേല. ഇപ്പോഴോ
Then he said he did not know.
മേളോട്ട്.
ഇപ്പോഴേ
മേളോട്ട്.
ഇപ്പോഴേ
താഴോട്ട്.
ഇപ്പോഴേ
താഴോട്ട്.
The one mistake what is incorrect.
അറിഞ്ഞൂടെങ്കിൽ അറിഞ്ഞൂടാ. ഇപ്പോഴോ
താഴോട്ട്.
ഇപ്പോഴോ
താഴോട്ട്.
ഇപ്പോഴോ
താഴോട്ട്.
വെരി ഗുഡ്. അതേപോലെ ഈ മതി 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 ഈ കാല് ചെയ്യും. ഇതിൻ്റെ പുറത്തിട്ട്
ഇത് വെക്കണം.
ഒഴിച്ചുകൊണ്ട് പോവാ. മോളി
What
പോലെ
is the left toe?
താഴെ മുട്ടിക്ക്.
Possible to
ഇനി ഇവിടെ ഇവിടെ വെച്ച് ശരി മതി.
Okay. Now look at the gait of the patient. Stands and
നോക്കി കണ്ണ് തുറന്ന് നോക്കിയേ.
even with eyes open, he tends to point the person inside.
താഴെ നോക്കിയിട്ട് നടക്കും. അവിടെ അവിടെ നിൽക്കും.
But with eyes closed,
താഴെ നോക്കി നോക്കി നടക്കും. താഴെ നോക്കി നടക്കും. അതാണ് നമ്മൾ നോക്കി നടക്കും. കാലകത്തിയാണോ നമ്മൾ വീഴത്തില്ല കാലകത്തിയൊക്കെയാണ്
Was for major tendency more towards
ഉള്ളത് ഇങ്ങനെ മുമ്പിൽ വെക്കാൻ ഞാൻ രണ്ടുപേരും ടിപ്പുണ്ട് മുമ്പിൽ വെക്കാൻ നോക്കിയിട്ട് അങ്ങനെയല്ല തൊട്ടും ഇങ്ങനെ ടിപ്പുണ്ട് വേണോട്ടെ ശരി മതി മതി കൈ കൊടുത്താൽ എഴുന്നേക്കാൻ പറ്റുന്നു ശരി മതി വരൂ ഇനി എൻ്റെ കൈ പിടിക്കാനല്ല ഉപ്പിട്ട് പോകണം
the slightly weak on the left side.
മതി മതി
Then also put it down.
ഇനി ഇങ്ങനെ
Under pressure plus no.
ശരി മതി മതി മതി
So summarizing the finding, left pupil is small but no ptosis. Motor system no wasting. Tone power normal in both upper and lower limbs. Mild weakness of the left dorsiflexus and left DHL on the left side. DTR upper limb biceps supinator normally visited. Left triceps is absent. Right triceps is normal. Both finger flexion absent. Lower limb, both knee checks were absent. Both angle checks were elicitable. Plandas indefinite. From the sensory system, touch normal throughout. Pain decreased in the left lower limb, say up to the inguinal region, compared to the right lower limb. Decreased in the right side of the, he also said it is decreased slightly on the right side of the abdominal wall, just up to the D2. But what is definite is there is an altered pain sensation in the mid chest upward bilaterally. He did not feel the sharpness in the upper chest, but he feels the sharpness in the lower part of the abdomen. Touch is normal throughout. Vibration JPS is normal in the upper limb. The lower limb, vibration decreased in the anticipatory leg spine and over the knee bilaterally. This consistently he was telling he is not able to feel. But it is preserved in the angle and in the toes. When vibration is decreased over the lower spine, he is able to feel from the say upper dorsal spine is able to feel. JPS upper limb is normal. The lower limb impaired in the big toe. Normal, almost normal in the right toe. Right toe is said made one mistake. The left also is able to tell most of the time, but made more mistakes in the left big toe. Rest was normal. Stands he falls to the left side. Tandem walking most effective, which you already see. So if you want the findings I have written, the main finding is the sensory system. So where is your localization in this patient? Take your time a little bit, 1 more 2 minutes, you can think about it and come to me, give me the possible localization.
Sir, could you tell again the sensory findings, sir? Pain.
Yeah, that's very, as you said correctly. I'll tell you once again. If you want, I can show the video, that part of the video once again. But this is sensory system, I'll tell once again. The reference also is important. Biceps supinator normal, left triceps is absent, right is normal. Both knee jacks were absent, both angle jacks present. Sensory touch normal. Pain decrease in the left lower limb up to the inguinal region compared to the right side. This decrease in the right side of the abdominal wall, this is vertigo, that you can skip that thing. But what is definite is that when you take the pin up, he said he feels the sharp pain in the abdomen, lower abdomen. But from the mid chest upward, he feels that it's a flat pain. You know, or even Padarikana, I mean, it feels as if you don't feel the sharpness, but it is spread out. That is what he's telling in the mind. Then vibration JPS normal in the upper limb. The lower limb, vibration decreased the anticipatory leg spine and over the knee bilaterally. But able to feel in the knee and the ankle and the toes. Vibration decreased over the lower, also the lower spine it is decreased. But upper spine it is well, it's able to feel very well. JPS upper limb is normal. Lower limb impaired in the big toe, but except for one mistake, he set it correctly in the right toe. And he's got ataxia while walking.
One definite lesion is a cervical intramedullary lesion, so in view of the patchy sensory and predominantly involving the trunk, but it could not explain will not explain the whole symptoms and the findings. Additionally, radiculopathy could be considered, so myeloradiculopathy type of pictures.
Okay, good thought. You think it could be an intramedullary lesion? It's a very likely possibility in this patient. The possibility you said in addition to radiculopathy or only intramedullary lesion can explain?
Additional radiculopathy in view of the change in the reflexes in the lower limb and the left foot weakness, and also upper limb absent reflexes.
The triceps is absent on the left side, agreed, but there is no sensory finding in that upper limb. The lower limb and the lower, the trunk and the upper part, the reflex loss can be explained by intramedullary lesion extending down.
But the left foot weakness we can't explain.
Left foot weakness you can't explain. You can explain that thing could associate pyramidal lesion or the lesion extending down, then involved in the anterior onset. But that reflex is not lost.
So the patient definitely doesn't have any definite UMN findings, because the majority of the findings are low motor neuron type, because he has got different radiculopathy, like reflex loss in the upper limbs, that too in a patchy distribution in the trunk and the abdomen, the lower limbs and the upper limbs. So I would definitely put forward a multiple radiculopathy, that too predominantly sensory, but motor radiculopathy is also affected. Something like a predominant radiculopathy. So what is the type of radiculopathy, whether it's infective, inflammatory, that is difficult to say. But I do feel that it's not a cord or any other lesion, radiculopathy.
Right, good thought. Okay. But only point against radiculopathy is that he has got whole pain is lost entirely on the left side of the trunk from below downward. And he has got a bilaterally, he has got a jacket-like dysthetic sensation in the upper part. That can occur.
Abdominal reflex is absent.
Abdominal reflex is absent.
But the vibration can't be explained by the radiculopathy.
Vibration can be explained. Only thing is that involve the upper root, lower S1 roots and all spared. S1 roots has to be spared.
It has to be a myeloradiculopathy.
You think it's a myeloradiculopathy?
Because the upper limb reflexes along the left triceps reflex was absent. Other than that, all the vibration, everything was normal. So that cannot be explained with the myelo. So down the lesion, there will be a patchy spinal cord involvement, mainly intramedullary, could explain the pain.
That kind of jacket like thing, including
yes, sir. Yes, sir. And that can only that only can explain the preserved angle reflexes with the absent knee reflex. Because if we even if we consider if it is a radicals alone, we may not be able to explain the jacket-like sensory loss at the level of chest, which is more likely to.
If we stretch your imagination, we can think that particular roots are also affected. That means, can explain that thing, but it's not.
But in that case, how can only the sensory radicals get alone and without involving that much motor involvement?
Yeah, your point is well taken. Yes, only it has to sensory radicals has to be affected. That's right.
Yes, sir. Yes, sir. Because if the ataxia is, it could be due to spinocerebellar or really posterior quadrant, because vibration is impaired.
Okay.
So vibration over the knee and on the back of the spine does not correlate to one root node.
Yeah, that can explain. Only thing is that roots has to be affected, but sparing the lower roots. Okay.
But that does not is not affecting the sensory pain. Only vibration is involved. That is very unlikely in the radiculopathy. only vibration involved in the knees and back of the spine with pain and temperature preserved, especially on the right side.
Yeah, correct.
The another thing is that if the radicals, if we are involving the chest, if we want to explain the sensory deficit at the level of chest by radical involvement, how could that the touch is spared and only the pain is impaired?
Yeah, correct.
Cannot explain.
The touch is preserved, pain is
Yeah.
preserved.
So that cannot explain with the radical. The
Touch-
dorsal roots are affected. If all the roots around chest are affected bilaterally also, how
Yeah.
can there can be discrimination between the touch and the pain?
Okay, that can occur unless there is a patchy involvement, no? The roots
Yes.
are affected very selectively, patchily. That's a little odd, but can occur. Theoretically possible, right?
Okay.
Right. So what do we want?
And
to
history-wise, also, I was telling the burning of the back, sir, which is more common with the intramedullary lesions.
Yes, burning of
the burning pain in the chest,
the
the mid,
back.
and he's also got a burning pain entire lower limb, something like a tract. That also you can.
If it was a radicular pain, then it would have been increased with coughing, sneezing, and radicular kind of pain he was not telling. He was telling some burning sensation on the back of the chest.
Okay, right. So what do you want me to do now? Let me see before that, these are the possibilities. In intramedullary lesion, monoid is multiplex and multiple radicular. These are the things you have to keep in mind. Okay. The patient came with an MRI brain. Okay. I'll show the MRI first. This is a flare sequence. And you see a lesion there, flare hyperness lesion, near the occipital horn on the left side. Another one on the right, deep parietal region. This is also T2 hyperintense. You can see the T2 hyperintense lesion. This is also T2 hyperintense in the right parietal region. This is a coronal cut. If you look very carefully, the hyperintensity is more towards the periphery than the central part. I'll show one more thing. This is the sagittal flare. This is T1, it is hypo. There is no blooming in SWI. And this is a contrast. This is a pre-contrast. That is fat sat sequence. It's a pre-contrast. This is with contrast. You can clearly make out an enhancement there. It's more towards the periphery. Central part is less enhancing. The lesion on the other side. This is the diffusion weighted sequence. There is actually no diffusion restriction. The hyperintensity is more in the periphery, just like your prior sequence. The central part is less hyperintense. It's a diffusion T2 shine through effect. The ADC is also is bright. But if you can think that maybe some peripheral part, there may be a diffusion restriction. Because if you look at the central part, it is not diffusion restricting, but there is some suspicion the brightest area is outside. That area appears to be diffusion restricting. Look at the size of the lesion here in this part. So, what is the diagnosis now?
Is it met, sir?
Pardon?
Metastasis, sir?
I didn't hear you. Please, what?
Is it metastasis, sir?
Yeah, it could be metastasis. Could be.
Adam.
Could be Adam.
It's more likely demyelination. Probably it's involved in the brain, spinal cord, as well as the roots.
Okay. So
White matter. It's basically it's the where white matter, periventricular region, not in the gray white junction. Not much edema.
Not much edema. So it could be demyelination. I think Adam is also demyelination only. Okay, but mass lesion is possible, but there's not much of an edema as you correctly say. It's a well-defined lesion.
Or is it pumifactive demyelination?
Yeah, it could be tumefacted EMI lesion. Perfect. That's a thing you have to keep in mind. Tumefacted EMI lesion. That's all. Basically, there are different types of EMI lesion. Okay. Now, what do you want me to do now? Are you satisfied?
Spine imaging, sir. It cannot explain the spine, his spine tics, no, sir.
Exactly. You cannot explain spine things. So you want a spine imaging. So we did a spine MRI. So we did a very meticulous imaging of the spine. I can show various pictures. This is a cervical spine T2. Okay. This is a thoracolumbar spine T2. Yes, nothing seen in the thoracic part. Actual accident. Then lumbar T2. Groups are all down. Now to get lumbar due to space. Space means very thin cut. Sagittal space. Number T to be made out.
Space sequence.
Then thoracolumbar T2 spine. Suspicious, very, very suspicious. Might hypertension. Yeah. But that can be normal. But they don't say it's not normal. Nothing about
പേഷ്യൻ്റ് സമയം ലീഷൻ അവിടെയാണ് ക്ലിനിക്കിൽ കോറിലേറ്റ് ചെയ്യുന്നുണ്ട് ആ പാട്ടിൽ അത് സിഗ്നിഫിക്കൻ്റ് ആണ്.
Then T1 sequence.
T1.
Then thoracic axial.
T2 cervical അല്ലേ thoracic rib ഉണ്ടല്ലോ thoracic.
Did you share a suspicion about the ovoid here? That's it. Ovoid here. Forward like thing is not seen in the second. Then axial T1, that is not going to give.
T1 thoracic T1.
Then thin cuts it took again number region.
ഇതൊരു ഫോർവേഡ് ആകാമോ?
Reduced status suspicion that could be a flow oil.
ചെയ്യുന്നുണ്ട്. അതോ ഫോർവേഡ് ആണോ ചെറിയ സംശയമുണ്ട്.
Then the coronal cut. This sequence.
ഇത് സ്റ്റിൽ സീക്വൻസ് ആണോ?
Then lumbar again, coronal stiff. Then to get contrast, meticulous contrast, this is a pre-contrast. That is with fat set T1. I'll go to the contrast. This is the contrast, cervical region.
Dixon വെച്ച് എന്താ
Okay, thoracolumbar, this is a pre-contrast.
Again, even with
Then contrast axial. Then this is a thoracic contrast. Okay, no contrast. Okay. This is comparing pre and post. It's a lumbar plane and lumbar contrast. You can see there's no contrast enhancement. This is thoracic plane on the left side, contrast on the right side. Again, no contrast enhancement. So they repeated the brain spine study. Also same thing. You can make out the hypertensity there. Even face diffusion again we did. Periphery is more restrictive.
diffusion shine through.
That's
Periphery is more restricting than the center. Diffusion.
So this is the report. They said visualized brain T2 hypertension enhanced lesion, demyelination. So now, where are we now? Spinal cord imaging is normal.
Yes, sir.
Nerve conduction, sir.
No conductions. Before that, we should have a
Yes.
working.
Sir, there may be two pathologies. One in the brain could be a demyelination, like a tumefactory demyelination. And since he has a bilateral, starting from the upper limb, lower limb, reflex loss and sensory symptoms, we have to consider anti-honsel with spinal cord involved. Possibly, as you're mentioning, could be a flowward, something like a dural A fistula has to be strongly thought of in this case. The brain lesion may be different.
Okay. Now, let us analyze this case, how we should analyze.
Final epidural fistula.
Sir,
Bindu, I did not hear you.
So many flowvoids are there, sir. We cannot explain that finding. Spinal epidural fistula has to be ruled out.
Flowwords, see, we are little doubtful about that. In the axial cut, such this called CSF flowwords can occur. That can mimic a true flowword, but that's not seen in the sagittal cut.
Yes.
So you're not very sure about that.
so some of the sensory symptoms can be explained by the central lesion also.
Yeah, it can be. It can be explained by that, but he has got a pain loss, waning pain. That all difficult to explain with the central lesion there. Let us see how we analyze the case here. Now, what is his main symptom by which this patient has come? Imbalance. Okay. And the weakness is there, which is very mild. That cannot explain his imbalance. His main problem is he cannot walk without support. The first question is it sensory ataxia or cerebellar ataxia? What is your impression? Is it cerebellar or sensory?
Sensory.
So then if it is cerebellar, it has to be a vermin lesion. So let's exclude a vermin lesion in this patient. These are the things you have to keep in mind. If it is sensory ataxia, maybe due to posterior column involvement, due to PMS affection. Now, was it a vermin lesion? Obviously, no, because there is nothing in the vermis in the MRI. And the sensory findings and the burning pain along the lower limb cannot be explained by a vertigo lesion. So I think we think away from a cerebellar lesion accounting for this ataxia. Now, next question is, if it's ataxia, it has a sensory ataxia. If it's sensory ataxia, it may be lesion maybe in the posterior column or a peripheral nervous system involved. Maybe in the nerve, maybe in the root, maybe in the ganglion, maybe in the root. Anywhere in the sensory pathway can put a sensory ataxia. Let us go by one. Now, if we say, let's see it's a posterior column lesion. There is no lesion in the posterior column, but that does not exclude a posterior column lesion. For example, for a paraneoplastic tractopathies, continued patient, posterior column may not be, even subacute combined degeneration, hyperintensity may not be seen all the time in posterior column. So seeing absence of a lesion in the MRI in posterior column does not exclude a posterior column lesion. Then, but there are other points. If it's a posterior column lesion, how to explain the sparing of the JPS and vibration over the feet? But vibration is lost of the anticipatory iliac spine and the knee. That is very odd for any posterior column lesion. Okay, then, but when you not seen the MRI, that is, as already told, the paraneoplastic myelopathy. Odd points, the patchy sensory loss, jacket-like sensory loss, etc. You can't explain. It's also got a pain loss, decreased pain at least on the left side of the trunk, left side of the lower limb. And the vibration is lost on the anticipatory leg, spine, and knee, not in the ankle and toes. So that next thing you have to wonder, is the patient sensory findings, is patient bluffing or not? Okay, that's the thing which you have naturally is sensory, is not fitting with our what we go with the posterior. So these are the things you keep in mind. Well, let us see what's it a sensory ataxia. Not posterior column, then PNS lesion. Is it a peripheral neuropathy in the peripheral areas? Obviously not, because there is no distal symmetrical affection. Peripheral neuropathy affected the toes first or the ankle first before it affected the knee and anticipatory leg spine. And moreover, it will not produce vibration sensory loss over the spine, because peripheral nerve means after the spinal nerve is from the ganglion, it is divided into dorsal root and dorsal primary rami and ventral primary rami. So the peripheral nerves will not usually produce it, whereas vibration sensory loss there. It should be inside the root or the ganglion. So that is obviously not fitting with the peripheral neuropathy. Now, two possibilities now remain: ganglion neuronopathy or a sensory radiculopathy. Posterior column affection is another thing which you can give with remain with, but we already mentioned this thing points against the posterior. Now, what do you want me to do now? So we have.
Sir, could it be the parietal ataxia, sir?
Pardon?
Parietal ataxia, sir. Could it be?
It's not. Its lesions are bilateral, and he has got a reflex loss. As a sensory loss is patchy sensory loss. Pain is also impaired.
No, sir. Only the gait, sir. Only the gait cannot be the parietal ataxia. If you exclude the sensory findings, only the ataxia could it be the parietal.
What you said is correct. He has got a lesion on the right parietal region that can produce an ataxia to the contralateral side. That can be explained. Okay. Now you want, what do you want now?
Nerve conduction studies.
Okay. Let's see the nerve conduction. The peroneal is, as already told, his weakness is confined only to the left EHL and mild weakness of the dorsiflexion. And this the left peroneal angle jack, no potential is picked up. Right peroneal is amplitude is decreased. So it's affected right peroneal as well to an extent. But remember, he is a diabetic also. Now, right ulnar is normal, left ulnar is normal, median is normal. Sensory potentials are all normal. No sensory potential. All are normal. Except for the median distal latency prolongation. Forget about the all diabetic will like carpal syndrome. Now, FA, we look at the FA, all are absent. Absent in the peroneal, but all are prolonged. All other conduction velocities, amplitude normal, distal latency normal, but FA is prolonged. Now, what is your localization?
CASP, sir.
Okay, very good. Any other possibility? You're perfectly right, Umar. See, the first thing we have to consider, as you already said, in the peripheral nervous system, two localizations, ganglion neuronopathy and CSP. Why ganglion neuronopathy or CSP? Because it is the one which produces patchy involvement. It does not respect a distal symmetrical fashion. I'll give you one clue. Somebody coming with a sensory ataxia, and you find a normal vibration joint position sense. Think of this condition, ganglion neuronopathy, because the sensory loss or proprioceptors may be confined only to the proximal joints, like hip and knee. That will produce ataxia. When you examine, you find what do you normally do? You check the vibration, the angle at the toes, and then walk off, telling that the sensory, its vibration sense is normal. Nobody ever checks over the vibration sensory loss. You can't check the joint sense in the hip and down. The vibration sensory loss and the anterior superior leg spine over the knee. We don't usually do. When you find it is normal, we take it as normal. But remember this particular point. If somebody has got an ataxia, sensory ataxia, or ataxia which is worsening at night, and you find distal joint sensor vibration normal, always check the proximal part. If so, you have to think of a ganglion neuronopathy, or just proximal to that radiculopathy, sensory radiculopathy. Okay, so we have two possibilities. Ganglion neuronopathy, is it no? Why no? Because SNAPS is normal. With ganglion neuronopathy, SNAP should be normal, abnormal. Yes, SNAP should be, SNAP is absent. That
Sir, in this case, the FO is abnormal. So, can it occur with ganglion neuronopathy?
Never. I'll come to that. So, is it a CASP? Yes. Very likely, CASP is just like ganglion neuronopathy, except the SNAPs and because just as we discussed last time, it is just but a proximal extension of the ganglion. So, its pattern is exactly the same as ganglion neuronopathy. Remember, it can be confined only to the torso or the proximal part of the shoulder joint, with sparing the hand, and this can occur with CASP or ganglion neuronopathy. And usually, the large fibers are affected in ganglion neuronopathy. That does not mean small fibers cannot be affected. If ganglion cells of the small fibers are affected, you can sense pain also. So, how to explain the sensory ataxia now? With the normal SNAP, at least in the sensory radicals or the posterior column. These are the things with normal SNAP. The points again is the posterior column, which already said. So what remains is the sensory polyradiculopathy. Why? Because of the patchy affection. And now comes Umar's question: how to explain the prolonged FA? You can't get it. If it's purely motor root and nerve function.
Sense radicals.
Pardon?
Sense radicals are affected, so you will get all
Okay.
the others will be preserved, but the phase will be prolonged.
Correct. So that means he has got not CASP, CASMP. That is chronic inflammatory sensory motor polyradiculopathy. So what is the evidence that motor roots are affected? The FA is prolonged. Why the proximal lesion is there? Because distal latency is normal, conduction velocity is normal. The lesion has to be proximal. Okay. This can explain the proximal lesion, demolish the presence of normal distal latency and conduction velocity. There is, in addition, there is a decrease in amplitude in the conperoneal nerve. That may be due to the associated diabetic problem, or it can also be explained by a distal conduction block in the conperoneal nerve. But not in the proximal part of in the mid part, only the distal can explain, or axonal parts. Both are possible. That which we can't differentiate. So this is the one decrease in map amplitude. It's an additional axonal affection or a distal conduction block in the conperoneal.
Sir, how to describe the, explain the patchy, continuous sensory loss in the abdomen and chest?
Okay. Now that's entire left lower limb, no? That is the thing which should you think more like a tract involvement. But taking the whole picture into consideration, because it can affect CASP or CA ganglion can affect all the nerves, 3/4 of the nerves, some of the nerves, or all may be affected, some may be spared. It so happened that the large fibers are affected bilaterally, the pain carrying ganglion or the roots are affected only on one side or predominantly on one side. That is why you're making some confusion the upper trunk. Upper trunk, the trunk, you said sometimes its pain is less on the right side, less on the, you're just confusing that area. So now how to prove the point? You have to prove your
CSF study, sir. CSF study.
or you have to look for a contrast enhancement of the root. But there is no contrast enhancement of the root here. We already shown you the lumbar roots. Even that's not contrast enhancement at all. So where you want to CSF, and this is the CSF. 114/44 protein, normal sugar, cell count. So that's a clue that its radicals are affected. It's inflammatory radical.
Sir, but the total duration is only 23 weeks, 20 days.
Yeah, no, 20 days, correct. You said is correct, 20 days.
So is it a first experiment?
You can call it as an ADP phenomena. It's also possible. But that's also possible. But this in pure sensory radicular affection is more common CSP, but that entity is also described in AAD, but much less common. Pure sensory AAD.
So the brain lesions?
Brain lesion is, of course, demyelinating lesions. So what he's having is, let us see, he's got a central plus peripheral demyelination affecting the motor roots and the sensory roots. That is, this patchy affection is also called the pattern mimicking a ganglion neuropathy. It will not respect a peripheral neuropathy pattern. Depending upon which roots are affected, you can have patchy.
So why can't we call peripheral nerves or multiple nerves? The ankle is preserved and knee is absent.
Yeah, multiple nerves, it does not fitting with the nerve pattern at all. And a nerve lesion will not produce a vibration sensory loss over the spine.
But the roots also is not symmetrical, no? So one side, left side, more of pain is involved.
Yeah, that's correct. That's exactly what happens in ganglion neuropathy or in the root lesions. Because it's a patchy involvement. That's why initially said, if somebody comes with sensory ataxia and preserved angle jerk and absent knee jerk, think that is a proximal radicals are affected. Not that does not occur with a peripheral neuropathy like that. Mononeuropathy multiplex, yes, but in that case, the motor and sensory involvement should fit in with a multiple nerve pattern. It is not. Patchy here and there is affected. Multiple radical protein pattern is affected, not nerve pattern.
One down. Yeah, when you say patchy, does that mean that the pain fibers sometimes affect the radical more than that?
One, the involvement in the roots may be patchy, the sense that some of the roots may be affected, some of the roots may be spared. That is why they initially told the example, it may affect only the proximal roots, sparing the distal roots. The person coming sensory ataxia with sensory, distal sensory, always look for that. Already said, no? That means patchy involvement of the roots. In the roots or in the ganglion, it can be usually confined to the large ganglion cells and the large fiber roots, but it can also affect the small fibers.
Okay.
If the ganglion cells or the pain fibers are affected, bipolar neurons or the pain fibers are affected, pain loss also. That's also not against. See, one of the presentation of ganglionitis is severe pain. For example, post-HIV ganglionitis, severe pain, paraneurologic severe pain. Site of action is the ganglion because the pain fibers are. Now let us see this patient. So this patient is given IUMB for 5 days. Let us see the follow-up of the patient.
കൈ നീട്ടി പിടിച്ചോ.
It's also normal previous vertigo.
വിട്ടോ 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 വിട്ടോ.
Specific is improved.
മുള്ളോട്ടെടുത്ത് മതി. ബലം കൊടുക്കരുതേ, ബലം കൊടുക്കരുത്. ചുമ്മാ ഇട്ടാൽ
It's
മതി.
very initially absent. Biceps is still absent even. Right side is. It doesn't need it. The absent. Now it has come back. It has come back.
തളർത്തിയിടണേ. ശരീരം പറയാമല്ലോ, പറയുന്നുണ്ടോ? ഉണ്ട്. ഇപ്പോഴേ ഉണ്ട്. ഇപ്പോഴേ ഉണ്ട്. ഇപ്പോഴേ ഉണ്ട്. ഇപ്പോഴേ ഇപ്പോൾ ഉണ്ടോ? ഉണ്ടല്ലോ. ഇപ്പോഴേ ഉണ്ട്. നോക്കി കണ്ണ് തുറന്ന് നോക്കിയേ. താഴെ നോക്കിയിട്ട് നടക്കും. അവിടെ അവിടെ നിൽക്കുന്നത് താഴെ നോക്കി നോക്കി നടക്കും.
Sorry, this is the wrong video. This thing, sorry. The video which we have been inserted was wrong. I think this is the previous one only is inserted. I wrongly inserted it. I will show that thing for just 1 minute.
Nerve biopsy is needed for this case.
Just 1 minute. I just want to get that video for you. Okay, can you see this video now?
Yes, sir.
Yeah, I'll show the video after treatment. The previous one was before.
താഴെ നോക്കി താഴെ നോക്കി താഴെ നോക്കിയാണോ? തിരിച്ചു വന്നേ, തിരിച്ച് തിരിച്ചു.
But less than 50. Yeah, please. No, I think nerve biopsy is not required. Nerve biopsy may not pick up anything here because lesion is in the ganglion and the radicals.
So what is the final diagnosis we have to say, considering the brain lesion also, sir?
It's actually central with peripheral demyelination. Central plus peripheral demyelination means it's got a brain, like an atom. Brain is affected plus the peripheral nervous system is affected, but that happens to be mainly in the sensory and motor roots. Something like CADP or ADP, which you can call. But affecting predominantly the sensory roots. That's the point you have to keep in mind. The disability is due to the sensory radical.
Sir, is it something like a Miller fissure because the pupils also affected here? So
No.
that
The pupil is not affected. Pupil is only mild anisocoria that is reacting well to light, and it's not like a Miller fissure. In Miller fissure syndrome, the sensory ataxia part is something similar to that, but here it is not that. Here it is the impairment of posterior column sensation will be there. In Miller fissure, sensation will be normal, and the involvement is in the appearance of the muscle spindles. They could global areflexia, ataxia due to the absence of muscle sphincter.
Sir, SSCP and should we do for this patient because confusion is there?
Yeah. SSP is definitely useful to find out the lesion in the proximal radicle or the posterior corner. Yeah, that cannot differentiate whether it's the root or the posterior corner.
Actually, post-COVID, so many atoms placed.
Yeah, there's very many patterns, very typical patterns are seen. So I bought this case only because if we are difficult localization. Initially, also I thought seeing the trunk lesion, also I was thinking in the central lesion. Plus, as Umar was telling, spinal cord plus root, that is something I had in mind. But nothing in the spinal cord. That's why we did such meticulous study. Then we started thinking whether lesion is only confined to something like a CASP. Or if we don't CASP, I thought ganglion neuronopathy, that is why I took NCV. And the NCV came, ganglion neuronopathy is out, then comes the diagnosis of CASP. Because we
what treatment you gave, sir? IV methylprednisolone? Why?
Bindu, I couldn't. Your voice
What
is.
treatment did you give, sir? IVIG or IV methylprednisolone?
IV methylprednisolone only, not IVIG.
Okay, sir.
In fact, what I was planning to give him, if I told him that if he did not respond to this thing, I plan to give rituximab. Why rituximab is, in fact, when Murthy sir has already told me that he has seen many cases of ganglion neuronopathy. They do not improve with IVMP or IV this thing, IVIG. They used to improve only with rituximab. The JMK Murthy from Hyderabad, he has told me once like. So I was planning to, but luckily he improved by IVMP itself. I took a repeat MRI after 5 days. The lesion in the brain has actually increased in size. Little bit increase in size. But nothing, I only wait, nothing to worry about. Someday the lesions may initially increase, then come back again. So I'm planning to do a repeat MRI after 2-3 weeks. A repeat conduction study. But clinically, it's much better. Reflexes come back. And the vibration sense which was not able to feel in the anterior spine has come back. But still ataxic.
Sir, I think rituximab is effective only in certain specific antibodies. I think anti-MAG or something in CIDP. Not all CIDPs respond to rituximab.
Yeah, you're perfectly right. But this is this you can't call this a CDP type one which we used to talk about. This is ganglion neuronopathy is little different from CADP.
Okay.
In the CADP, there are various types of this thing. That is neuro. That's called the neuropathin 155, 168. Those things are there. Some of them respond only to steroid. Some of them respond to rituximab. Some of them does not respond to either. But these antibodies are not done here.
Yes, sir.
Neuro.
GM1 antibody panel.
GM1 antibody panel can be done.
So considering the duration of illness, can we give him directly IVIG rather than giving IVMP?
No, you can. You have got a justification in that. You can try IVIG in that duration. But any CADP going for it's a subacute phase now. It's progressing, but usually it's not the type of an ADP pattern which you see here.
Okay, sir.
Multiple roots or multiple ganglions are affected in a patchy fashion. How many ADP have you seen with lost vibration angular joints in the hip with the preserved joint JPS and this thing in that? I described classically in ganglion neuronopathy or CAS.
Okay, sir. If this F5 abnormality is due to diabetes, so can it be just CISP?
No, CISP will not produce, we cannot produce any prolonged FA. Prolonged FA means motor roots or motor nerves has to be implicated.
Yes, sir, but if that is the chronic problem because of the diabetes. Like,
No, diabetes will not produce a prolonged FA latency alone. No, it can always just be, see, diabetic neuropathy usually is axonopathy, but demyelination can also occur, but predominantly axonopathy. So here the prolonged FA latency indicates a demyelinating pattern, and that too proximal, only in the roots or the proximal part of the nerve, not in the distal part of the nerve. That is unlikely to be a diabetic pattern.
So there is in the recent one neurology journal, it was written a CASP plus pattern.
Yeah.
That, as you said just now, that proximal demyelination, that they have.
That's why the name given as CASMP. That means sensory chronic inflammatory sensory motor polyradiculopathy. The evidence of motor polyradiculopathy is a prolonged FA latency here.
They have told to differentiate CASMP from CASP plus.
Yeah, I don't know. I'm here the CASP plus, maybe the CASP may be one category coming under CASP plus.
Okay.
That means CASP plus means CASP plus a motor part is also.
So should we consider the secondary causes of CASP, sir, in view of the brain lesion is not responding to steroids?
Yeah, definitely we have to consider. But the thing is, the peripheral part is responded. Even brain lesions in DMI, they remain for a long time, may increase for transiently, then only come back. So we'll do a repeat MRI. If it is regressing, then of course we will wait. Otherwise, we have to investigate further. As you said, we have to look for secondary causes. Definitely, we can.
Repeat MRI at 3 months, sir?
Pardon?
Is it repeat MRI at 3 months?
No, I am planning to do it after 3 weeks.
Okay.
By the time we start improving, no? That's what I.
Brain lesions, why should they increase in size?
Sometimes, in Adam, it is described that you can have a progressive, even if the patient started improving, the brain lesions can worsen. That's well described in Adam. Especially children may progress, but the patient started improving. That did not directly correlate with the improvement. That described in Adam. Similarly,
sir, how common is sensory ganglionopathy common in Adams, sir?
No, it's not common in Adam. What I'm talking is that this is a central plus peripheral demyelination. Central demyelination is producing Adam-like picture or tumefactor demyelination. The peripheral demyelination is affecting the roots and the motor, sensory and motor roots, predominantly sensory roots. That's all.
Sir, I have a patient. He's a diabetic. His blood sugar is around 200. He had shoulder pain as well as mild neck pain, and he used to keep his arms on both sides, keep it on the head, which would give him some relief. But this problem is that he has got wasting of the scapular muscles, and this deltoid is slightly wasted. And though he has sensory symptoms and pain, there is no sensory loss. Maybe there is a doubtful sensory patch. Then very, very doubtful. So I have to go on. The upper lateral part of the deltoid region. All the reflex absent because he's a diabetic. No sensory impairment. His weaknesses in the deltoid, biceps, and infraspinatus. All other muscle groups are normal. And this conduction showed axonopathy. Amplitude drops in the deltoid and the radial as well as in the musculocutaneous. Synapse normal.
That looks like an hemiatrophy in this, neurological hemiatrophy here.
Yeah, but the snap is perfectly normal. Like with this sensory symptoms and pain, can this snap can be normal?
Snap is usually normal. Even motor conduction is usually normal in neurologic hemiatrophy. Maximum you get a decreased CMAP amplitude. The sensory pattern, sometimes you can get musculocutaneous, but most of the time it is normal.
Okay, sir.
Most likely this is, and this is also quite common in diabetes also. Neurological.
Okay, sir. Because I was wondering whether this could be some C56 radical of because the deltoid is weak, the biceps is weak, and the reflex are lost, and and he has a neck pain also, which is there for the past 3 weeks. So continue, and the MR shows some, as usual, some sporadic changes, canal stenosis and all there. But clinically, this looks like a neurologic amyotrophy.
Yeah, I think so. The neck pain, even the radicular type of pain, also can occur with the neurologic amyotrophy. It can exactly mimic the root pain of cervical disc, but the pattern of involvement is the one going to help you. The case of radiculopathy, the muscle weakness and this fits in with the root pattern. The neurologic amyotrophy more fits in with the nerve pattern.
Here the pronator diabetes is normal in this case. Pronator is normal. So supposing that it's a C5-6 root, how do we specifically say that it is not in the root or in the plexus? In that case, because here the deltoid and biceps both are weak.
But deltoid is weak, biceps is weak, supra-infraspinal is what is brachyradialis?
Brachyradial is normal.
That's a point favoring a plexopathy. Because if it is a C5-6 root involvement, you expect brachyradialis also to be decreased. And you expect that supinator eject to be diminished.
Yeah, all the reflex are lost because there is a diabetic.
So that point is going to help. Only the power part is going to help.
Yeah, the pronator also normal and the brachyradial is also normal.
That's a point favoring a plexopathy.
Okay, sir.
So in this case, why the second option of the treatment you have kept as rituximab, not IVIG?
Your point is well taken. I could have very well given IVIG. The only thing is I told before, what I heard from Dr. Murthy from Hyderabad, he had a lot of experience with the ganglion neuropathy. I had a talk with him sometime back in a conference. He used to tell me, if you want ganglion neuropathy, they don't usually respond with these things. I go 2-3 patients, I give rituximab, they responded. Only because of that thing. I could very well give IVIG also, no problem.
How aggressive it should be? How long to wait for the response for methylprednisolone?
That's a difficult question. See, usually what we give is we give IV or things, we for 1 or 2 weeks we wait. If not, we go for the next line. It's not a condition where the aggressive has to be AADP like condition. AADP let me little aggressive. Even about 5 to 6 days does not respond, we go for the other thing. But here we can wait a little more.
Okay.
Or steroid has to be continued.
If I continue for 2 weeks, I was repeating about response. It is responded dramatically with this injection itself. So I thought I'll continue for 2 more weeks and review the patient once again.
Without oral steroid, man.
Okay, shall we close now? Sorry, it's going to be 9:50. Okay, next week I'll bring another interesting case, something similar to that.
Thank you, sir. Thank you.
Thank you very much,
Thank you,
sir.
sir. Good night.
Thank you very much, sir.
Thank you, sir.